Bob Keenan's our next speaker, Assistant Professor of Medicine, Division of Rheumatology at Duke. He's Medical Director of the Duke Specialty Infusion Center, and he's also Director of the Duke Gout and Crystal Arthropathy Clinic. He received his bachelor's degree at UNC Chapel Hill. He was an MD degree at St. George's, resident at St. Louis University, and a fellow at NYU. He got a master's in public health at Chapel Hill, and he's getting an MBA now through the University of Massachusetts. And he's going to give us a gout update.
All right. Well, thank you, David, for the invitation to speak. And after that intro, it looks like I do everything but see patients, right? Let me see if I can get used to this real quick. So, again, I want to talk about gout, and I was expecting standing room only, quite honestly, because this is gout. What else do you want to hear about? This is one of the best topics ever. And hopefully, I'm talking to a bunch of rheumatologists. When I speak to primary care docs, I feel like I know more than these guys. I can easily talk about this for hours and hours and teach them something. And hopefully, I'll be able to teach you guys something as well, too, because in my experience, over the last, I got out of fellowship 5 years ago, and my experience over the last 5 years is that rheumatologists think they know a lot about gout, but sometimes they don't know that as much as they think they do. And it's not necessarily they might even actually forgot it, or they might not be applying what they learned in fellowship or in training and pass it on to their patients appropriately, or just because of time, et cetera. So hopefully you get some kind of a pearl or two from this talk. My disclosures. I'll start with the patient case. And I saw this patient about, I don't know, it's probably a year and a half, 2 years ago maybe. And this gentleman presented to the clinic after being referred to by his primary care doc after about 5 years of intermittent right knee swelling. Just one knee would kind of come and go every 6, 7 months or something. I got a relatively active guy, wasn't overweight, no major medical problems. And he had seen a couple of orthopedists, and he had seen, of course, his primary care several times. They treated him with NSAIDs, which gave him some moderate relief, but usually over about a week, 2 weeks maybe, the swelling would eventually resolve for the most part, and he could get back to his regular activities. He had a father with a history of gout and a grandfather history of psoriasis. So, you know, when the fellow presented this patient to me, he said, well, this guy's coming in with monoarticular pain and swelling. It's a little bit full right now on exam. And he said that, he said it might be some kind of psoriatic, presentation, or it might be some kind of reactive presentation, or it might be just, of course, a mechanical derangement of some sort. He's a 35-year-old guy, relatively active. So, and I said, well, what about gout? He said, nah, no way. This guy's young, he's healthy, it's just doesn't seem like gout. I'm like, okay, well, let's take a look. So the labs he came with, you can see here, and the only thing that really stands out where his cholesterol was a little bit elevated and his triglycerides were elevated. His serum urate was, quote unquote, in the normal range, which I saw documented several times by the primary care doc, serum urate normal. We can talk about primary care docs, right? We're all rheumatologists, so we can talk about them a little bit. Okay, so the x-rays that he came with as well showed an unremarkable knee x-ray. The MRI that the orthopedist took saw a Baker's cyst, which you can see right there. I guess it's projecting okay. See right there. And then a possible vertical tear through the anterior horn of the meniscus. But they didn't think it was anything that would explain his recurrent symptoms, of course. So the differential diagnosis, as the fellow was telling me, mechanical derangement, seronegative, maybe some kind of weird palindromic rheumatism, reactive arthritis, and infection, of course, is less likely. And of course, I threw in that crystal diagnosis as a possibility as well. So again, hopefully you guys will get out of this talk something today, and something you can hopefully take back and apply to your patients in everyday clinic. I'm going to go over some of the, for good or for bad, or for better or for worse, some of the new ACR guidelines for the management of acute and chronic gout, which I know are somewhat controversial, but at least